Thanks everybody for coming. I think that I'm so happy that Eileen can be here first of all to talk to us about, what is really going on down here in Broward. And then, we can talk more. Is she still on? Yeah, you are. Good. And then she can talk more about that, and we can there's a lot of other things going on if people are interested. So Eileen, do you want to start? And Eileen is the director of the Michael Benjamin Center, an abortion clinic here in Broward, and I came upon her because she is one of the clinics that our Broward Women's Emergency Fund provides assistance to when the young people or of whatever age need financial assistance getting an abortion. So, and the clinics are screened for ones that do great work. And so her clinic obviously does. And I was just eager to speak to somebody. And this was like number 2 on our list on the survey of importance of things to talk about, somebody on the ground in Broward. So maybe Eileen, if you can just tell us, your background and how you got into this work and how long that you've been doing it.
I helped a friend that was opening an abortion clinic in Miami, and I started doing counseling a couple of nights a week. And I became very passionate about helping women through this special time. Back when things were legal and there were very few restrictions, it was more of an issue about just making sure that they had the funds and transportation. And of course, as things have changed and evolved lately, it's accelerated the need for extra services that we never imagined. So part of what the women that we are seeing are challenged by are having to visit for multiple appointments and for having to travel away from their home state to get an abortion. So from counseling to administration, I've never really left the counseling. So I always have my, a really good sense of what women are going through. And many days I bring home intakes so that I can call women during evening and hours, or when it's a little quieter at home, if they don't work. And so the need is there. It's a great, great need for money to be able to fund this. And it's very distressing when they've missed having an abortion in their home state by just 2 or 3 days, like whether it's elective or whether it's for a therapeutic reason. It's just as distressing to the woman.
And so you do more counseling. You're not on the medical side.
I'm not on the medical side. But I work very closely with the doctors, and because I've done this for so long, I think that there has to really be a great liaison, between the two sides, as so many people will have medical problems, drug use, medications that they're on. There's just medical conditions relating to the pregnancy. So I'm often talking to the doctors that are referring their patients. Like today I had a doctor begging for a patient who was carrying a baby with Klinefelter syndrome. Well, it's not fatal. It's not fatal. She's 20 weeks. She has to travel, and she's coming to see us tomorrow to see what we can do about finding her a clinic and getting her the assistance that she needs.
So then you work with getting her someplace out of state to
exactly
get the abortion.
Exactly.
So how are you seeing your work changing, with all of the restrictions that are going on from when you started?
So a lot of time goes into explaining that they do still have an option. They tend to close down when they can't imagine having to travel to another state or how that would take place. And some people have never flown. I'm surprised how many people, I don't know what an airport is like. So drawing a diagram and explaining TSA and what to expect at a different clinic. Sometimes I'll have pictures of other clinics so that they can see what it's going to look like when they're inside, if they're Creole speaking, and there's a lot of Creole speakers in Broward, actually. There's ways that they need extra support. So how has this changed is that we've always wanted to make sure that they've considered their options, that they're sure of their decision. All that remains standard. But what changes are the physical limitations of having an abortion. So it doesn't seem like a big deal to have a 24-hour waiting period. It's the transportation. It's the not wanting to lose that job that they just got, that they can't leave 2 days in a row, that their days off don't coincide with their partners or their friends that are going to be transporting them. So honestly, the funds have been so helpful, because when we have the ability to even use Lyft or Uber to get people, move them, in town, not only if they're from out of town, but if they're in town and they don't have that transportation. Sometimes we're in a shelter and they have zero, right? So I think that it's really important to just be able to consider each person individually. That's why I said that. Somebody asked me, oh, can anybody do this? You can, anybody can, but just for you to know, it's a long game. It's not just a short game of here's the name of clinics, call, because they need a lot of support in this. This is something foreign to us,
Mm-hmm. Maybe you can explain for people that don't know just exactly what the legal hoops are that are required, even before we're going into this legislative session when we don't know which ones they're going to add.
We are very fearful of that, aren't we? We're very fearful of a 12-week or 6-week ban. But where we are right now, a patient has to either have a 24-hour waiting period between the time that they have their first appointment, which must include an ultrasound and a face-to-face contact with the physician, who will tell her how many weeks she is, explain the procedure, and ask if she has any questions, and then answer them. Those are the requirements. The only way around them is if the woman's health is so that she's in such distress that it's a medical emergency, or if the fetus is carrying fatal fetal anomalies. So, sorry, I misspoke. Everybody has to have the 24-hour, including rape patients, including a 14-year-old rape patient that was there on Friday. So everybody is 24, only if there's a demise, so if the fetus has already passed away, you don't have to wait. Other than that, everybody, whether there's an anomaly or not, whether it's fatal or not, still has to have the 24. Then once they come in for their second appointment, it's only available within the first 15 weeks of pregnancy. So before the restriction for 15 weeks, the gestational limit in Florida was through the end of the 24th week. Now, this was something that we were very respectful of, even though if you read deep into the law, it was 24 weeks from conception. So it really would have been 26 weeks, but because we never trust that they could circumvent that law, we've always been respectful of 24-week exactly. So when they changed it to 15 weeks, they didn't do it 15 weeks from conception. Now they did 15 weeks LMP. So that meant, 13 weeks of gestation. Pregnancy is quite small. There's no chance of viability. And sometimes by the time that people understand that they're pregnant and find out what to do about it, they're past 15 weeks. So that's the point at which only if it's a fatal fetal anomaly can they terminate it here until 24 weeks, which is what the state has set as viability. I believe strongly that they're going to change that viability limit to 22 weeks. So even even with these fatal fetal anomalies, I don't think you're going to be able to go that far pretty soon. And so if they are within 15 weeks, you can do the procedure on that day. If there's a big problem with the pregnancy and you have to have 2 physicians to sign the form. So it's not enough that you have medical records, not enough that their doctor is sending them. There must be 2 physicians that are signing the form, saying that the fetus is not viable and will not survive. They will die imminently, is how they phrase it. So another important issue about that is that there's a lot of contradictions between the doctors themselves as to what that means. So you may have a doctor that says, yes, cystic hygroma, this baby's gonna maybe last 6 months. Well, other doctors will say, well, but that's 6 months. That's not imminent. Imminent to them might be within the first few hours. And they're very, very worried about signing that dotted line and putting
myself.
their license into question.
Sorry, go ahead.
So that's where we stand right now legally. And I know that there's challenges with everything. There's challenges right now with medication abortion. And the way that
Yes.
to our patients is, for example, with what's standing right now, if you're from a different state and you're coming into Florida to have an abortion, like National Abortion Federation will not fund patients that are going to have medication abortion unless that they're going to stay in the state and pass the pregnancy here, or go to a state where it's legal. So if you're from Texas, you're coming here, you're 8 weeks and you're going to get medication abortion, you'd have to stay an extra 2 or 3 days to make sure that the pregnancy passed and we could verify that.
Mm-hmm.
So it's more probable that the patient will seriously consider having a surgical procedure instead, even though that is something that they really don't want. So it's an added layer of restrictions to somebody who's already having to leave their state, travel across the country, and put their health in the hands of people that they don't know. It's not like we're not part of their community. They're just meeting us for the first time.
So who did you say puts that in position on them if they're traveling from out of state?
Well, National Abortion Federation.
I missed it. Oh, okay.
NAF.
Okay.
And they supply the major part of the funding to their major clinics,
Okay.
to their member clinics.
Oh, that's interesting. I did not know that.
Have you seen any changes in the number of women needing abortions?
For needing abortions?
Have the numbers changed?
Oh, yes. Well, in the last 3 months, our numbers have gone up quite a bit as far as the number of patients but now medication abortion is almost 50% of the patients we see. So the past 2 years, it went from being 25%. Steadily, it's increased almost on a month-by-month basis. So that now we're just at the 50%. I think last month it was exactly half of the patients.
But the number of patients has not gone down or changed.
We thought it would, but what has changed is that the second trimester patients that's changed quite a bit. Those have gone down because we saw a lot of patients between 15 weeks and 24 weeks. That's when most of the anomalies are detected.
Yeah.
You know. So and there's many people who also had elective abortions at that time, and they have as much right and as many different reasons as you can imagine for doing it. You know, for making that choice. Mm-hmm.
What percentage of patients come from other states, or do you have an idea?
We keep them. We keep those files segregated. I don't really count them, but we see maybe 5%.
Oh, that's
So
not.
like if we saw, let's say that we saw 400 patients.
Mhm.
How many, can you talk to how many repeat visits you get?
No,
Can you?
we choose not to. We
Okay.
choose not to.
And in the process of intake of these patients and seeing them through the end of the procedure, what in Broward County, if anything, what kind of education, if any, is being offered to them about birth control so that you don't have to see them again?
At our facility, it's part of the counseling model. So the first part is the consent, their decision making. I mean, at the bottom of the counsel, in our counselor notes, we have a checklist, and I have actually a fill in the blank. So that whatever counselor it is asking them, how can we support you through contraception? You know, there's some people say, I don't want any. So, you know, we do the roundabout. And so, well, what we're using this time when you became pregnant, where, you know, that's a good way. Well, I use condoms. So do you think you had a failure on the condom? They'll say, well, I didn't use it this one time, and that can happen, right? And other people say, birth control doesn't agree with me. So, you know, we have some great charts that tell them, you know, let's look through what didn't agree with you and see if there's anything else that might. The Women's Emergency Network is very supportive of the LARC grant that they have for long-acting reversible contraception. We used a Liletta IUD on that grant. Our funding is a little bit limited. They're very, very generous with what they give us, but we try to use as much as possible for patient care. But maybe around 2 or 3 patients every month can get an IUD. But it comes right from how can I explain it? It comes right from our budget.
Yeah.
So that's hard. And they just opened something up very interesting. They just told me that they decided that it's not restricted just for women who are going through an abortion. So let's say that somebody comes in, they think that they're pregnant, they go through ultrasound and everything, and oh my God, I'm not pregnant. Well, they can still qualify for the free IUD. Or it's not really free. We actually ask for them to contribute towards it. There's people who can and people who can't. So it's on a patient by patient, you know, basis. We're screening for.
Where do you get your funds, Eileen, for your operating budget? You're talking about having to pay for this out of the clinic's budget, right?
Right.
So
yeah.
Where do your monies come from to operate your clinic?
From our clinic itself. From our clinic, we are a for-profit business. It's not a non-for-profit.
Okay.
So we're not really, we don't rely on funds that are being donated, you know, for our operations. And we try very hard, you know, to make it a successful business because we need to continue to offer this. And, you know, it's a very, very difficult time.
Yes.
It's probably more than you all want to know, but like right now we're thinking about, do we need to either raise our fees or do we need to drop our malpractice insurance so that we can give the kind of raises that we need to give so that these brilliant people that work for us don't go somewhere else, because salaries have risen tremendously in healthcare. So I've lost a couple of people to hospitals. One of my key people is considering moving out of state because they can't afford housing in South Florida, you know, working for an abortion clinic. And she says, well, I love what I do so much that if I move, I wish I could pick up my job and take it with me because I adore it. And I love the mission, you know. So those are some of the ins and outs of what we do.
Thank you. Thank you.
What are your fees approximately for an abortion? Do you?
I couldn't understand.
Sorry.
I believe she asked, what are your fees?
Hi, I'll plug this in. Can you hear me now? I was just asking,
Yeah.
are your fees, is there a fixed fee or is it a sliding scale according to income? What are your fees?
No, our fee is $650 for first trimester care.
Mhm.
We will try our best between what the patients have and funding to meet that. It's important to us, so we try to collect on our fees. We've tried things like payment plans and having them sign agreements to pay a little bit later, even if it's just a little bit that they had left. And Marilyn, I've had to really throw all those agreements away, shred them, because very, very few, I mean, a handful have ever paid back. So if we need to take a discount on a patient, we will, but nobody's ever not going to get an abortion at our facility. That's something that Dr. Benjamin had us pledge, that we would do whatever. There's usually a patient somewhere along the line and in the year, usually it's towards the end of the year. Sometimes, remember, Joanne, when when funding would run out by October or November, and we had to send out more letters, like at the end of the year, asking for donations, one more time. And sometimes we would run out of money, and sometimes we would do patients, at no charge. We try not to, but it may happen, or it may happen that we don't cover, some patients completely. Sometimes we put them, we have very generous budgets now for helping people travel and have a place to stay. I can't tell you how important that is. It's so important. But sometimes they show up and they don't have any money to eat. So, we make sure that we have that covered for them, whether they're taking food from the clinic or we're Ubering some food to where they're staying. Those are some of those things. Or how do they get back to the airport if they're traveling from far away and they've got to us? Well, maybe we'll have to Uber them back or take them from the hotel back to the clinic, because now there's these 2 appointments. So it's not enough that you get somebody who's traveling in from the airport to us, but they have to have the procedure done, go to a hotel, come back to us the next day, get back to the airport. So there's a lot of hardship that these patients are facing with the new restrictions.
Yeah.
Are you able to charge a cheaper price for medication abortion, or because of all the hoops, it has to be the same price?
Oh, no, not at all. It has to be the same fee.
Yeah.
And honestly, like the surgical abortions, I take call. So I take emergency call. My nurse and I switch off on that. And I would say 90% of emergency calls are medication abortion.
What do you mean by like people scared when they
calling,
choke up?
they're calling, they're scared, they're in pain, there's a lot of bleeding, even though you counsel them, even though they have paper instructions provided both by us and by the company that makes the medication. It's a difficult process for some people. For some women, it's just like a heavy period, but many times, there's strong contractions and, you're having to face something scary,
Right. So in terms of medication abortion, I don't know if everybody's aware that there is a lawsuit going on in Texas where medication abortion might likely be banned nationwide sometime after February 24th.
And that's after it's been legal for 23 years, right?
Yes, it's been yes, medication abortion is completely safe. It's been legal here since 2000, but it even started in the 80s in France and or in the 70s, I think, in France, and the 80s in Sweden. And anyways, it got here late and over a lot of objections from who. But the Alliance of Defending Freedom, one of those kind of fake groups, filed in front of a judge in Texas that he's the only judge in that area, and they know how he votes, or how he'll rule. And so they purposely kind of forum shopped to get this one particular judge. And they're arguing ridiculously that the FDA should have never approved the drug. They didn't prove it properly. They were too fast. They didn't do the proper procedure. It wasn't an emergency. A lot of things that are, for many reasons, both factual and procedural, are just complete baloney. But the abject fear of everybody is that doesn't matter to this judge, that he's a complete ideologue. And so plans are being made to be ready for alternative action. Like, what action is your clinic planning? Are you just planning to go, with one medication instead of two? Or maybe you can just give us a little explainer on how medication abortion works for those who didn't come to the medication abortion meeting last month.
So medication abortion, as it stands now, is a two-step process in which a drug called mifepristone, which is packaged very nicely individually, so it's very clear for the patient to understand what they're receiving, and has a lot of supportive literature with it. The patient must take that from the hands of the doctor. So it's not anything that in Florida we can mail or have our nurse practitioner give. So we're committed to having a doctor there to give each and every pill. When the patient takes this pill, it doesn't have any outward symptoms usually, very, very few. People will miscarry or bleed with the first medication, but it works to weaken the pregnancy and weaken its attachment. And in that weakened state, it's highly successful, about 97% successful if they use a second drug, which is misoprostol, which we would then dispense to them at that same appointment for home use. And we ask that they wait 24 hours, and then in the next 48 hours following that, at any time that it is convenient for them, hopefully that they might even have a support person if possible, that they would insert that between their cheeks and their gums, or vaginally, depending on what they and the doctor decide. And the next while after that, it could take us, I've seen it happen as early as like 30 to 45 minutes. Other people call you 8 hours later that nothing has happened yet. And I've had people miscarry the following day. But usually it's within like a 3 to 6 hour period. They start having strong contractions as the uterus contracts to evacuate the uterus. You'll see a lot of bleeding. They might see some clots. Rarely do they see the pregnancy, but sometimes they might see a sac. It's not that common. Of course, patients feel like they want to share that. So sometimes you'll get a picture on your phone on the emergency line saying, hey, I think it worked out, but it's not that common to be really seeing the pregnancy. And so it can fail. We request that people either do a home pregnancy test or come in 2 weeks later. We love it for them to come in. There's no extra fees or charges. And that's one of the things that you were asking before, like, could it be less expensive? It's a lot more labor intensive. We like to see patients if they're having bleeding that is too heavy. We want to check their hemoglobin again. We would like to, if their pregnancy test is still slightly positive, we'll do more ultrasound. We measure the lining. We see if there's debris. If there's debris, is it better for the patient to have that aspirated out? Because sometimes they're having cramping and pain, for an extended period of time. And so that's how medication abortion works. And it's working. People access it all the time. They find it less sometimes like I think that they're favoring the fact that it's just a pill, that they're thinking.
It doesn't seem so bad. So if this lawsuit would only ban mifepristone. Mifepristone.
Yes.
So then are you going to go to the misoprostol misoprostol only? And how would that work?
I think that Dr. Benjamin is leaning strongly towards providing this, even though it's even harder for the woman. Much less chance, about 10% chance that they will not miscarry with this. And they will have much heavier bleeding. So it's not as predictable. And I think that we are probably going to offer it because we don't want to let women down and block them from having the abortion that they're choosing. You know, like they want to have an abortion by pill, and we can find a way to do that. We would probably try to do that, but there may be some legal restrictions that providers need to consider. And I think that we've asked our attorney tends to be a little bit conservative. And the question of the misoprostol not really inducing the abortion or terminating the pregnancy, as mifepristone is billed to do. Okay, it's not that it always, but it weakens it so much it doesn't give it much of a chance. But if people don't use the second set of pills and the pregnancy survives, you know, that's a slighter chance of that happening. But with miso, you could have given the patient the first set of medication of the misoprostol. You would probably give them, I think it's 2 pills, like 400 milligrams, and that you would repeat this 2 more times. So a few
And
hours
is that-
apart.
So in a way, isn't it faster than the 2 together?
It all happens in one day, but it may not be as successful, and it's going to have a lot of bleeding. People may have many more serious side effects.
Right.
And
I'm sorry, go ahead.
take that pill
Right.
with the, as it is now. Yes.
I'd like to ask, has there been any conversation with your legal team about obtaining the medication by mail if you can't get it to the pharmacy or wherever you're getting it from now? There's been conversation about it. There are places where you can get it, where you can order it by mail. And the conversation has generally been, as far as I'm aware, that, you know, the state cannot interfere with the United States Postal Service. Does that play into any future possibilities for the abortion clinics? Do you know? Have you discussed it at all?
If we did that, we would be breaking the law. So here we cannot provide medication abortion by mail. The doctor must physically.
No. It would be mailed directly to the patient. I mean, I'm hypothesizing that all the clinic would do is provide information on how to get them by mail. I don't know legally where that where that would hit you. It's all too new.
So I think that's available on the internet, and I've known for years and years and years that sometimes people will buy pills from India, you know, where they will advertise and people will buy them. I don't know what percentage of people want to have an unsupervised abortion care. Some people do. I've had a minor that was very ill that was sold at a small pharmacy, misoprostol only, because after all, in so many countries, in Central and South America, that has been the primary way to have an abortion.
It's also an ulcer medication too, so they can't really, you know, pull it because it's used for other purposes.
Right. Let me explain for people that aren't too knowledgeable about the legal part of it, is that it's it's the second pill that would still remain legal is not part of the lawsuit because it is not approved necessarily for abortion use. It's approved for ulcers.
Yeah.
So it's a completely different animal. Not to say they might not target that another time, but for right now, it's going to continue to be safe. And it was sort of found by accident by women in Brazil, where they had notices on the medication saying, you know, don't take this if you're pregnant because it will induce an abortion. And people were like, whoa, okay. So then they started using it for that purpose. And only after it was really pretty popular in several Latin American countries did they even research it and find that, yes, this does work. I mean, it is, it is perhaps probably more painful, and it's not as successful, but it's still highly successful. So it's like Eileen is saying, a lot of clinics are already, and I was on a call with Planned Parenthood, a Planned Parenthood partner call on Monday, where they are definitely going to be doing this at the Planned Parenthoods to continue on with being able to give care, for as long as we can.
Mhm.
So,
So
that's the difference.
There's something that we are finding now. Is we need patients to be prescribed the misoprostol. There's many times now that the pharmacies are changing the easy dispensation of that, and they will call back and ask, what is the purpose of this pill? Was it properly prescribed? And we prescribe it for women that are like maybe over 14 weeks, a little bit post-surgical abortion to help contract the uterus. And it is being highly, highly regulated now. They're onto this.
I was going to
But the
ask,
thing
have
is-
we
sorry.
heard anything about the possibility of that being outlawed as well as the other drug?
I don't think so.
Nationally,
No, not so far.
Not yet, not yet.
Mm-mm. No, I mean, they're not targeting it yet, but yeah, that's a big problem. That's going to really hit like a ton of bricks. If it's like, I heard somebody say that today on a podcast, just that it might even be worse than Dobbs in terms of the impact. I don't know, because I guess Dobbs is different in different states, whereas this is going to be every state. I'm assuming that's what they meant. So,
In answer to Kathy's question, that's probably not going to happen because, as you said before, it's been approved also as an ulcer medicine, right? So it's probably less likely, fortunately, to be challenged, right? Is that correct?
mhm,
Or give them time.
mhm. Yeah. Do others have questions? Feel free to talk up since we're a small group here today.
Do you have any advocates in the community that do fundraising for your clinic, Eileen?
I'm not sure I understood the question.
Well, you need money to run your clinic. You said you're a for-profit organization. I'm asking if there are any organizations or people out in the community at large that, perhaps have fundraising events to help your clinic run. Raffles
No.
or sad parties or galas or nothing, no?
Oh, but there's such great support from the funds, and there's a new way to have funds cooperate together. So throughout the state, or sometimes even throughout the country, if it's a really large ask, there is a way that they align, and that your local fund will be able to put out an ask to the other partner funds. Can we help this one patient? And sometimes they'll give a of what is the need for that patient to get
Right.
somewhere. And that's
Right.
been amazing, just amazing.
So can you talk a little bit about judicial bypasses and how many you have and how successful they are? Because I saw a graph the other day that showed that the requests have really plummeted.
They have,
So I wonder, yeah, do you feel that's true? So what do you
I
think
feel
is like,
part of what I think is that,
well, wait, first, I guess, sorry to interrupt you. I better say what a judicial bypass is, or do you want to? Go ahead.
go ahead, no, go.
So a judicial bypass is simply when there's a teen that's under, what is it, 18? Or is it's not older than that, that they now need to not only have parental notification, they need to have parental consent to get the abortion. And if they don't want to ask their parent or guardian, they need to go to court to get that, which, some recent research found out is, not given all that much. And depending on the county, it's very county specific, let's just say, in Florida. But so they have to, it's a whole procedure where they need to literally get a lawyer and things. So I don't know how many kids you have needing it and how many go through it and how many just end up having the baby because they don't want to go through it.
So I don't know how many continue the pregnancy and have the baby, but if what they're trying to do is avoid talking to the parent, having the baby would be
The bad.
very obvious. But I think that I've only had, I think, one judge who denied the bypass, who felt that the young woman was not mature enough to make the decision. So I was not going to take that. And so she engaged her attorney to petition for a different judge. Because, I mean, if you're not able to make the decision, how can you raise a child? Was her framework very important. But I think that I do see a lot less judicial bypass. I wonder if part of this is the fact that abortion is so much in the news now that it's a credible fear, where before I don't think that the younger people really thought about it too much and they could easily get an abortion. But since it changes, and since in the past, I would say like in the past year, I think we're only seeing about half as many judicial waivers. Remember at the beginning of COVID that we still had so many people going through judicial waiver that we often would like my desk, which where right now I navigate people out of state or in state. It was a big part of my job to navigate young women through the judicial system to make sure that they were prepared. Go, what did that look like? Did they need to have an ultrasound before so they'd have more information? Because part of what they want to know is, what do you know about pregnancy? Are you sure that you don't want to do this? And so, for them to be able to give a complete answer, it's important that they be prepared. So I'm thinking that birth control and whether contraception through condoms or other things, I think that the message has been given. And also because abortion is so discussed, maybe they are actually speaking more to their families about it to get somebody to come in with them. Because of course, if they have that, then they don't need the waiver. So.
No, exactly.
Evidently, Broward is one of the better counties as far as judges approving. I mean, it's not perfect, but better than a lot of counties in Florida.
Yes.
County, and during especially during the lockdown time of the pandemic, those first 6 or 7 months, they would allow us to call them in the juvenile section. And because the guards wouldn't let anybody into the courthouse, they would come downstairs, bring the minor in, have them come up, fill out the paperwork, put them right in front of the judge in chambers, and it all happened like under the cloak. You know, it was amazing. What an amazing, what a resource.
That's wonderful. That's wonderful.
Too bad that didn't continue.
No, exactly. Hey, Eileen, have you had any protesters or any problems outside your clinic?
We always have had them. Right before the pandemic, they kind of got very aggressive in that we had found them even inside our building, even though they're not supposed to. They're supposed to stay on the outside of the private parking lot because we have a private parking lot. But we had a couple of people who did things like that. And we have had a very credible threat also last year on not publicized, let's say.
Mm-hmm.
So please let's leave it like that. But after the pandemic, they stopped coming. We used to have a group that was once a month from a local church. I think it's St. Kieran's nearby on University. And they would bring 10 or 12 people about once a month, and they would all stand like right near the area closest to the recovery room, which I thought was ridiculous because they had their abortions, so they're not stopping anything. But we also had a really crazy guy who would come a couple days a week with his megaphone and his boombox, and he would make up songs, you know, about us and know us by name and say, hey, are you in South Miami today, Eileen? Eileen, the queen of abortion. You know, you scheme to get people to have a, you know, like just like a crazy, crazy guy. But after really after the pandemic, he hasn't been back. We don't know what happened to him. We don't care.
I have a feeling he's at the school board meetings because I think I saw him there. Chris Nelson is who I'm thinking of. Yeah, that's a big problem for so many clinics. I saw today, though, that Planned Parenthood got a big award against one of those groups. It was really, really big. It was like $815,000 recovery of their attorney's fees and like $115,000 like civil judgment or fine or something against them for the crazy things they were doing. And I think litigation against these people is excellent if you know anybody can do it, because that I think is the only thing they're going to understand.
Was it a particular area? Was it a
I couldn't hear.
Which
it was in
Parent?
Spokane, Washington.
For them.
Yeah. So yeah, that's that. Big segue. We're almost at the end of time. Sex education, since we're talking, like I did bring up school board, there have been a lot of problems at school board meetings, and there's going to be a big one on March 7th. I just want everybody, hopefully. Yeah. So, okay, well then we're pretty much done. If anybody doesn't have any more questions, or Eileen doesn't have anything further, I'm just going to say thank you all so much for coming. And I'll be sending out some other emails because we have a meeting on Saturday, if you can attend as well, that I'll be sending more information about later. But
kudos to Eileen for what you're doing. Kudos.
Yes, Eileen, thank you so much.
Thank you.
Yes,
Thank you.
going to do, yes.
And also thank you for touching on
absolutely.
the sex education part in the schools. I mean,
Yeah.
I come from a
Well,
completely different generation. We had that when we were in elementary school starting there. And I grew up in Hawaii, so I'm shocked that the ignorance sometimes is beyond.
Yeah, it's hard for, I think, all of us to wrap our minds around.
But have a great
Yeah,
evening regardless.
Yes, everybody have a great evening, and Eileen, thank you so much.
And thank you.
Thank you.
All right,
Thank you for being-
we'll
Thank
see you
you
all
very
next
much.
month. All right, thanks, guys. Bye.